So I'm going to talk about two things. I'm going to talk about wicked problems and why maybe hand hygiene does or doesn't fit in that category. And then I'm going to talk about a new study, HRB-funded study we're working on to look at improving hand hygiene in the ICU. So firstly, what is a wicked problem? So it's a problem that is difficult or impossible to solve because we have incomplete or contradictory and changing requirements that are sometimes difficult to recognize. So within healthcare, this is generally applied to things like childhood obesity, affordable healthcare, antibiotic resistance, which we're talking about later, caring for old people, and perhaps hand hygiene compliance. So I'm going to present, I'm not sure if it really is a wicked problem, but I'm going to present some evidence of why maybe it fits within this framework reasonably well. So we all know how to wash our hands. Even my kids know how to wash their hands. So it's simple, and there's no shortage of research on hand hygiene. So like I said, I'm relatively new to this. 7,000, I think there's 7,600 papers, if you have a look in Medline, on interventions to improve hand hygiene. So we should know an awful lot about it, you would think. And in fact, we should have solved it. With that amount of research, God knows how many millions has been spent on that. A lot of research on it. But when you start looking, when you look at the Cochrane reviews, when you look at the systematic reviews in the area, you find criticisms such as the lack of methodological rigor. So often these studies are underpowered, for example. There's no theory in terms of the intervention, so it's not based on any theoretical framework of behavioral change. They're just sometimes they're thrown together things that people think that might work. Even when you look at those papers, so they're research papers, and the problem with us as researchers is that we don't often explain in that much detail what the intervention is. So there's lots of data on the findings, but maybe there's not too much to guide you on how you actually, within your unit, how do you improve hand hygiene compliance. That deep level of detail simply isn't there. And a lot of the times these papers aren't looking at the complexity of the environment or the organization that they're working in. So we know that ICU is complex. We know that ICU in GUH is probably different from ICU in Sligo. It's probably different from ICU in the States. It's probably different from the ED. So there's all these different complexity. The organization, the people we have there, all has implications for how hand hygiene is working there. This is an overview that Michael Power, the critical care lead who's involved in this project, drew of hand hygiene governance, deliverance, and delivery from hand hygiene in the Irish healthcare system. You can see there's a lot going on. There's a lot of different agencies who are interested and who are trying to improve hand hygiene and hand hygiene compliance. And there's considerable resources and money being spent on audit and on compliance in hand hygiene. I think, Michael, we estimated maybe about €2.5 million a year on auditing and trying to improve hand hygiene compliance. So just, even within Ireland, we're putting a lot into this and onto trying to improve it for good reason. Okay, so this is some characteristics of a wicked problem. So wicked problems, they came from planning, from housing planning, and now it's being applied elsewhere. And I'm going to go through these different characteristics and give you a kind of hand hygiene spin on each of them. So the first one is you don't understand the problem until you've developed a solution. So every solution that you have exposes new aspects of the problem that perhaps you hadn't considered, and now you have to adjust your solution to deal with this new aspect of the problem you didn't know about until you put your solution in place, if that makes sense. So we know that the way we control hand hygiene, the way we address hand hygiene is to conduct audits, and units and people in the hospitals get feedback on the percentage compliance. But we also know that people don't behave in the same way when they're being audited as when they're not being audited, which is no great shock. So if you do if you're watching people slyly, or you have some sort of electronic monitoring system compared to when we have the hand hygiene person watching, there's a difference. So you can see these two studies are an example. So the first one, 3-fold increase of hand hygiene events when auditors are visible, and 180% increase in hand hygiene compliance during an audit. So the very fact that we're being watched is affecting our performance. But you know what? It's even more complicated than that. So the Hawthorne effect is not constant, just to make things even more tricky. So if you're in a high baseline unit, if you're already doing quite well, and someone comes and audits you, there's a significant improvement. However, if you're in a unit that's not performing particularly well, and someone comes and audits you, there's not a significant difference in your performance. So the people in the low-performing units, they're not even trying to impress the hand hygiene people. That's how bad morale might be. So the good people, they want to impress them. Lower performing units, less so. So that Hawthorne effect is not even constant from unit to unit, just to make things doubly and triply more complicated when we're trying to evaluate and improve it. Okay, so I'm saying there's no definitive problem and there's no definitive solutions. There's no kind of stopping rule about saying, okay, we've solved this, let's move on to the next big thing. Here's an interesting solution these guys developed. So you might have heard about nudge. So nudge is a way where we try and nudge people into doing the desirable behavior. We try and make doing that desirable behavior, we try and make it as easy as possible. So it's been used in things like you have to opt out of pension schemes instead of opting in, or people have to opt out of organ donation instead of opting in, and then we get more of the desirable behavior. So you can see in their picture here, the hand gel is there behind the sink. So if you are a visitor coming into this unit, are you really going to go over there into the corner, wash your hands, and then come in? So what they did was they noticed that they moved where they put the gel. They put it at the door of the IC units. They were targeting visitors. They put up a little sign that says, here we use hand disinfectant. So they're trying to prompt you to do that. And then they get really sly to protect your relatives. So what kind of monster are you if you refuse to to wash your hands? That means you're not interested in protecting your mother or your child or your spouse. So they're putting the guilt trip on there. And this is what they found. It was a small study. If you compare baseline, so placement made a difference, but placement with the guilty sign makes an even bigger difference. They're nudging people into behaving the way that in the desirable way that you want them to behave. Through kind of simple, doesn't cost much to do this. But maybe it's obvious, but just by thinking about it and things maybe from a slightly different angle. Okay, so next issue, there's not a better, worse, there's not an answer. There's no solution. There's just a better, worse, good enough, or not good enough answer to your problem. I'm not being very positive about this, I get the impression, but anyway, this is where we're at. So if you look at the key performance indicators of acute hospitals around hand hygiene in Ireland, so the new one is they want people to be trained, and they get the rolling training every 24 months. That makes sense. They want you to use 25 litres of alcohol rub per 1,000 bed days. Seems to make some sense. I wonder about that one. I used to work in the Navy, and I know what an enlisted naval sailor would do with this. If this was a key performance indicator, they'd be over the edge of the boats, just like pumping the alcohol gel down the thing. But anyway, I'm sure Irish healthcare workers are much more honest than that. And then you look at, they want a 90% compliance rate. So why 90%? Why not 100%? Why not 80%? You know, what's the evidence what's the impact on infection rates if you move from 80 to 90? I don't know. So they're setting these rates, and so maybe they're good enough. But, you know, why these rates? Is there a basis for this? I don't have the answer to that, but these, I guess we're saying these are good enough. They're not dissimilar from other international standards, so that's where we're aiming for in Ireland in terms of our KPIs. Okay, so the solution to a wicked problem will always be custom design and fitted, as we're saying here. So if you look at, not just within hand hygiene, but if you look at a whole range of improvements in healthcare, we know that change is difficult to achieve. So if you think about looking at handover, for example, which people are talking about later, it's difficult to achieve a good handover. We have lots of issues in healthcare, and making that change is very hard. The question is, so does a hand hygiene intervention we found to be successful in one place, does that transfer to another? Maybe, maybe not. And the other issue is, sometimes it's very difficult to unwrap the impact of the intervention from the impact of the implementation itself. So maybe the intervention is effective, it's just the implementation that is hard. So we're working with a CNM in Galway, and they had a big hand hygiene compliance, a European-funded study to improve hand hygiene compliance. And I think they went up from something like 40% to 80% in that unit, I think purely driven by her strength of character. So if you took that and then tried to apply that somewhere else, if you didn't have someone like Katrina there to drive it, it may not have had the same impact. So not necessarily there's anything wrong with the intervention, but maybe it's the implementation. And this is huge, and unwrapping those is difficult. And we do this all the time as researchers. We say, okay, look, we've piloted our intervention here, but I was there watching you and patting you on the back, giving you buns and giving you all kinds of gifts to get you to participate. But then when we take that to another unit, and maybe that's not being minded in the same way, we don't get the same effect. So we need to consider not just the intervention, but how we implement that intervention as well. Okay, so every solution to a wicked problem is a one-shot operation. Sometimes, related to some of the earlier ones, you can't learn about the problem without trying the solution. Maybe you need to try something out to learn more about it. And again, if we're doing big interventions, these can be costly, and maybe there's unintended consequences of our intervention that we had not thought about. So I quite like this example. So this is quite old now. What they did was they modeled hand hygiene compliance. So this isn't necessarily real data. The real data is around the 40% mark. And they said, okay, this is 40%. Now, how long does it take for them to get to the hand hygiene gel? How long does it take to wash their hands? And they modeled this and said, okay, let's suppose we had 100% compliance or 20% compliance. How much time is being spent engaging in this hand hygiene behavior? So they had a 12-person, 8-bed ICU team working 8-hour shifts. So there's 96 hours of work going on there. And you can see even the bottom red line there is alcohol hand gel, and the other ones are hand washing using soap and water. You can say even if we have alcohol hand gel and we use it for 20 seconds, for me to get to 100% compliance, that's 4 hours of time these guys are spending of their 96 hours doing hand hygiene. So that's great, we've got 100% compliance, but that's 4 hours not doing something else. So as we increase the compliance, there's a cost somewhere. So maybe we need to add extra members to our team, or maybe other things aren't happening. And this isn't maybe something, I hadn't really thought about that until we read this paper. But there really is a cost in terms of hand hygiene. It means other jobs may not be being done. So it has wider implications. And you might not know that until you put your intervention in place. So they have no given alternative solution. There might be no solutions. There might be lots of solutions, or maybe there's solutions we haven't even thought of yet. And here's an example of two kind of indigenous Irish solutions to improving hand hygiene. We have Hygienex that have kind of remote monitoring. They have a little badge that flashes to look at whether or not you're engaging your hand hygiene compliance. And then the Surex wash system you might have used, where it's a kind of computer-based system that will watch the position of your hands and give you feedback on how well you are washing them. So it's complicated. There's no one solution. And I don't know. I wonder if there's a need for some big disruptive technology to come in place. Is that what we're waiting for? Where you kind of walk into the ICU unit and then it kind of sprays you with something and then you're clean for a period of time? Maybe that's what we need. So to conclude the wicked problem, so we made huge improvements in hand hygiene compliance. That goes without saying. The efforts that people have put in the front line in terms of, I appreciate hand hygiene is not the most exciting thing to do, but I think there's been an attitude shift in terms of frontline staff and hygiene compliance. So we've made great strides. Maybe it's not the wickedest problem. Perhaps, I don't know, maybe child obesity is wickeder. We can have a debate about that. But I think hand hygiene does share some of the characteristics. And it's not finished. I don't think anyone in this room would say, we have solved the problem of hand hygiene compliance, let's move on to something else. It requires continuous, sustained efforts even to keep where we're at, let alone improve. But it's hard. It takes a lot of effort to do that. So now I'll move on to the projects, having said that. So some of that has led into this HRB-funded project. So we only started in July, so I don't have lots of exciting results to give you. But I might tell you what we're doing. So the background, so the genesis of this project was from Dr. Michael Power, who is the National Critical Care Lead, and he recognized that hand hygiene was something that we should be focusing on. And then we were matched in a kind of strange sort of arranged marriage, which was this quality and patient safety initiative where I was in a book, and I guess someone selected me from a book and decided I'd make a great wife or husband for Michael Power. And then we got together and we formed a team to develop this proposal, which then wasn't funded. So as it often happens, I have more failures than successes in my career, and that was one of them. Anyway, so we kept going, and we took the comments on board, and we reapplied, and this time we were lucky enough to get funded. So with more money. So, you know, in some ways being rejected was good because now we have more money and can do more. So 3-year project starting in July, and most of that funding is around funding our postdoc, Dr. Sinead Leiden. So here's our team. So it's a multidisciplinary team, although you might notice that it's quite psychology heavy, or psychologist heavy, and actually the reviewers noticed that. So we had to explain why we needed so many different psychologists, although I would argue we are different kind of colors of psychology, so we had to bring different brands to it. But we have a kind of wide-ranging from nursing, critical care, social marketing, as well as psychologists. So these are the principal and co-principal investigators. We were worried we didn't have enough psychologists, so we've got some collaborators who are also psychologists to up the psychologists there again a bit more. And we have these other people who are named collaborators to give us some advice on what we're doing. So the aim was, or is to get input from all stakeholders here. So the whole idea is this is kind of bottom-up, top-down, sideways. We want everybody involved because we know, like I was saying, my colleague there in GUH, it's hard work to put in a big hand hygiene compliance kind of intervention. Maybe it's too hard. Maybe we can't expect everyone to do that all the time. She was saying there was a big sigh of relief in the unit when that intervention ended because you just can't keep working at that level. So the idea, and we wanted to use a unified approach. We wanted it to be scientific based. Like I said, the methodologies were kind of weak on the papers we reviewed. And we wanted to draw upon improvement sciences and draw on what is known to try and develop a scientific approach to improving hand hygiene compliance in ICUs and in Irish ICUs at that. So 2 parts. So we wanted to understand what's going on, both from the literature and both in terms of what's going on the ground. And then the next part we're going to develop. Notice not deliver. I was really worried that there's no way this is ever going to be funded because we weren't actually going to do any intervention. And I think a lot of the nurses we've spoken to about this are a bit disappointed and can't get their heads around why there is no intervention and who would be crazy enough to pay for something where there's no intervention. But I think some of this is the point. I think a lot of the problem with the studies is a lot of the upfront work they've rushed the upfront work, what's the problem, and they've rushed to the intervention. So fortunately, and much to my relief, the HRB has agreed with us and were willing to fund us for 3 years to really try and understand the problem so that when we come up with an intervention, it will hopefully be effective because we've done the groundwork properly. And it's not just because we want more funding for the next year. I mean, we're trying to do this properly. So we base this around Mitchie's behavioural change wheel, which is, so we have the behaviour in the middle. So if you want to think about hand hygiene, you have capabilities. So is the hand hygiene gel there? Have I been trained to wash my hands? The opportunity, can I do it? Again, are the opportunities there? Am I motivated to do it? So from some of the interviews we've already done in ICU, the complaints are it's the visiting surgical teams that are the least good at washing their hands. I think that's the most correct way of putting it. But as we know, what happens if a senior person comes in and they don't wash their hands? So healthcare is quite hierarchical. All the more junior people following them are going to engage in the same behavior. So maybe they're not motivated because I don't mean to blame surgeons. But perhaps if you have the senior guy is not washing their hands and the other people aren't, and this has implications for behavior. So this is the kind of the structure, this is the theoretical foundation that we're working from. Then if you go up one more level in the wheel, we look at the function of the intervention. So is there a reward? There's different types of interventions that we could propose. You could give people prizes, I don't know. You could punish people. In America, sometimes people lose their jobs if you don't do well in your audit. I don't necessarily think that's the best way of doing things. You give them skills training. Maybe you give them skills not so much in education, but the skills might be around empowering juniors to speak up. Although when I worked in aviation, I always used to say there's no point empowering the co-pilots to speak up if you don't encourage the senior leadership, the captains, to listen. It might be the same in healthcare. But an array of different types of interventions. So what's the function? What are we trying to do? So we're really trying to think about what these interventions are and how they might work. And this all needs to sit within the policy framework. There's no point having an intervention if we don't have the funding to implement that intervention, or staffing is not available to implement the intervention, or it doesn't sit with the guidelines. So this all has to sit within a policy. And you could argue even further out, this has to sit within the national culture. So there's even an even bigger cultural issue going around. Some of the hand hygiene papers are quite interesting in terms of the work was done in Muslim countries, and there was issues with having alcohol in the alcohol gel. So people weren't using the alcohol gel because I believe the alcohol can be absorbed through your skin. So there's this bigger cultural, national culture that is sitting in on top of this. All of this is kind of coming in and affecting the guy at the sharp end on whether or not they wash their hands. So we're looking at the whole array through the range. So the first part we're engaged in now is understanding what's going on in the environment, both from the person at the sharp end as well as from the regulator perspective. So what's the compliance? What are the barriers to hand hygiene compliance? And do they differ between different hospitals, which I think they do. There's local barriers that aren't the same everywhere. We want to consolidate the different hand hygiene guidelines, look at the standards, look at the policies, look at what's common between those policies, and look at what's different in terms of guiding people. We want to talk to the key policymakers as well as to see where they're coming from. And based on all of this, we want to analyze what's going on in the Irish healthcare system in terms of regulating, in terms of interventions to improve hand hygiene compliance. Because sometimes things are working very well at the local level, and not everyone necessarily knows about that. And then we want to take all that evidence, and we want to develop a sustainable, and that's the big issue, that's the big thing. So we don't want an intervention that kills everybody, they can only do for a few months, and everyone's like, thank God that hand hygiene psychologist has left, because we've had enough of him. We want something that can be sustained in the long term, and we think a complex intervention, most of them are where you have bundled interventions to improve compliance. And again, we want to involve all the stakeholders in helping us to develop that. So it's not just coming from the psychologists, it's not just coming from the policymakers, it's not just coming from people in the system. We want to try and get something that will work, and that involves input from everybody. So where are we now? So we've started doing our interviews with ICU staff. We're going to analyze those. We're going to use those to develop a questionnaire. We're going to do some direct observations across 4 sites, and we're interested a lot in around whether they're occurring at the right moment and a bit around the quality of the hand hygiene moment as well. And again, that will be built in, and we'll feed back to our expert group and use them to help us identify something that will work. That's the goal. So like I said, we're interested in all opinions from everybody. We are not the only experts, or we're not necessarily even the experts in hand hygiene, so any input from anyone would be brilliant. And that's Sinead's number. She's the postdoc, and that's my number. And thank you for your attention.